Okay, Australia. Well, starting with primary care, Australia was part of a study done, quite a good, probably one of the better inter-country studies, particularly beyond Europe. Studies by Kathy Schoen and her colleagues at Commonwealth Fund with lots of money. Did quite a good and quite rigorous study of these 7 countries. And it showed that Australia, in terms of the primary care, the use of technology by primary care, i.e. EMRs, they identified 12 functions, 12 different functions, and they collected data about for each country as to how many were using what functions. And you can see that Australia ranked up there. Most of the countries ranked up there except for Canada and the United States, which are embarrassingly far behind the rest of the world in terms of use of technology by our primary care. However, that's the Australians' primary care picture, which is not too bad. They've made very little progress on their EHR agenda. As Dick said this morning, they spent a lot of money. A lot of money. Just as Ontario spent a lot of money trying to move their agenda forward with very little progress. Australia has done the same. As late as October, the government said we're just not going to make any major investments. Doesn't mean they're not going to make some investments, but they basically have taken a hold-back routine. And I was privy to a document 2 weeks ago, which is an internal Australia document, not public yet, and it's full of wills. So Australia is in the intentions stage. Okay. And you know, if you crudely rate them as a country where they if you do a crude rating, highly subjective, based on very shaky data, they definitely, in my sense, they're definitely the bottom third. So 25 countries you might consider.
So with Australia...
Now, let me just clarify one thing. As we're saying that doesn't mean there are not pockets of excellence inside Australia. Okay? There's some excellent systems in some of their hospitals. They have quite a nice little primary care system in New South Wales. So it doesn't mean there are not pockets of excellence. Just that's true for most countries. Okay, Canada, there's some real pockets of excellence. When you look at it nationally, how are they doing? They're not doing very well.
So, I mean, they're doing well with those 12 functions and, you know, there's pockets. But in terms of integration across Australia, because you had mentioned about, you know, can we connect at local and then regional and then national? Is that more their focus? Is more on the local regional provider versus...
Nationally, they want to develop some degree of interoperability, interconnectivity. Right? And even in some of the regions, they want to try to achieve that even within their region. So Australia, it looks like Australia's taken a step back. They've gone back down to the summary record. So they're going to concentrate their energies on the summary record as opposed to the comprehensive record. So,
I might be wrong about Australia, but isn't it a large rural section as well too? How does this translate for those numbers for like the rural primary care communities?
well, from the point of view of primary care physicians in rural Australia, they perhaps, if that number shows that only 80% are using technology, it's quite likely that 20% are not, but probably rural areas. The other thing that Dick mentioned, which is another important facet in terms of primary care, is, and I don't know what the numbers are off the top of my head in Australia, but it's also quite likely that the 20% of physicians, not primary care, family physicians, not using technology in Australia are single practices, solo practices, okay? Which was the model of the past for most countries. Solo practices, working alone, still common in some countries, completely changing in other countries and banned in other countries, literally banned. Okay. Policy set, there shall be no more solo practitioners. We will group the solo practitioners into centers. Okay. All right, let's move on.
Dennis?
Yep.
Scotland?
This
Are you
one?
sleuthing around the confidential internal government documents?
No, I was given to it.
It was
They
given
asked-
to you.
They asked me to comment on it. It wasn't,
So we're not allowed to broadcast that?
yeah,
or-
that's right. I'll probably take it off
Okay.
the thing so you won't even see it. You've seen it, but you won't see it. Yeah, no, it's, they asked me to give them a comment about your intentions. Okay, New Zealand. New Zealand is up there. I would put New Zealand in the top third. Again, crude, very crude. Definitely the top half, possibly the top third. High penetration of technology in GPs, like virtually almost every GP. High degree of functionality. They have also, which most countries don't have, quite a high degree of clinical message exchange between GPs and particularly hospitals and laboratories. What they don't have, and they haven't been able to grasp with yet, is the prescriptions. Okay? They're still doing, well, they've solved the prescription. The first part of e-prescribing is eliminating the handwritten prescription. So all the New Zealand GPs now enter the prescription into their computer systems and print a script, which the patient is given and takes to the pharmacy. Okay? Whereas here in our country, we're still to a large extent receiving a handwritten script which we take to the pharmacy. The next stage of e-prescribing is the aspect of, well, does that physician have a decision support capability to help in terms of finding adverse drug events, contraindications, so on and so forth? In most countries, that's very limited because it depends on having an up-to-date medication profile. You can't check for contraindications if you don't know all the drugs. And in New Zealand, the only really drugs that they have in each physician's office is the drugs that they themselves prescribe. They may not have the drugs that other physicians prescribe for that patient. The next part of the prescribing cycle is to send the prescription electronically from the physician's office to the pharmacy. And that's basically only happening in 2 parts of the world. That's Denmark and Sweden, and to a minor extent in the Netherlands. Okay? And then we get into other aspects of the prescribing cycle, but those are the sort of 3 at the front end, so to speak.
I just wanted to be clear, Dennis. When you're talking about the adverse drug reaction elements within the system, does it have any of the CPOE type of functionality? Or
CPOE, okay, CPOE is a functionality of physician order entry, although who's doing the work on CPOE? Can also be considered provider order entry, okay, as opposed to physician order. But the original term was computerized physician order entry. And CPOE is often also particularly, not totally, physicians have all sorts of orders they make. The big 3 are laboratory orders, imaging orders, prescription orders. Okay, but then there's also other kinds of orders, referrals to cardiology for EKGs and so on, physiotherapy for treatment. The big 3 are lab, imaging, and drugs. Okay. CPOE tends to be also put in the context of physicians, of medications, and basically, for the most part, either ambulatory clinic attached to a hospital-based or hospital-based. So it tends not to be viewed in primary care in that fashion, okay? But in some ways it is. In some ways it is. So I'm not sure if I answered your question. I did some explaining about CPOE. But for that adverse drug event, for CPOE in its power to help in the decision support, remember we saw the original definition of what a CPR was way back? Remember that? How for all of you remember that? Say yes. The Institute of Medicine, original definition. Decision support, including reminders and alerts. The alerts are often counterindications, okay? Potential adverse drug events. if that drug is given to this patient under these conditions, up comes a warning. Okay?
Yeah, and that's what I was,
To do that, you often need to have a comprehensive medication profile. So the physician enters an order for a particular drug. The decision support capabilities will then check against the drugs the patient's already been prescribed and see whether or not there's going to be some problems. Okay? Good? Yeah.
The 100% penetration, that's due to mandates? Is it mandated that
No,
they use it?
well, no. The New Zealand stories are very similar. Dick told you that there are different reasons. Probably the major driving force for why New Zealand is so automated in primary care is that was one country that banned solo practices. The country was going bankrupt, literally going bankrupt. New Zealand, what, 10 years ago, 15 years ago, they were going bankrupt. They made some radical changes, reforms across all of government, including healthcare. One of the healthcare reforms was no more solo practices. You must form yourself into groups. In their case, they let the physicians group themselves. And I think they said the minimum must be 5 family physicians and even more. So they created organizations called IPOs, I think independent provider organizations. And they were large enough that they needed managers. Okay? And so run this new organization, community health center kind of organization. The managers tended to be much more computer literate. And they started using the computer to automate the billing process. Then they started telling the physicians, well, we could start getting lab results electronically. And they drove the agenda as much as, and then the physicians picked it up themselves and then started expanding the agenda. But probably the major driving force was the policy decision, which had nothing to do with computers, to say we don't want solo practitioners anymore in this country. Okay. So that's their story. And then there's some other aspects of it too, but that's probably the major reason. This is their stated government aims, and this is only probably 4 or 5 months old. And you can see establish a national architecture, none currently exists. So they don't have a national yet approach as to how they're doing it. They're struggling with the concept of interoperable records as opposed to a single record. Okay? The notion, and that's why I asked Dick this morning to sort of clarify what he meant by one patient, one record. Okay? Because it makes a big difference if that's at a local level versus a regional level versus a provincial level or a national level. There's some groups within New Zealand who want one record for the whole country because the population is not that large. Other groups don't want a single record. They want to be able to exchange data across records. So that's what that means. There's still a strong in New Zealand. England, we could spend 2 days on England, okay? And I'm just going to cover just England is probably the country with the oldest and most strategies, confirmed, written, public statements as to what they're going to do. Okay? Probably the lead country in the world, going all the way back to 81. Okay? The biggest one that's had the biggest impact and carrying all the weight, of course, is the strategy of 2002, where they committed to investing £6 billion to new pounds to the EHR agenda. Okay? That has not worked very well, unfortunately, and they're now in a state, particularly with the new government, particularly with a hung parliament, which means a minority government. There's a huge, huge question mark as to what the future of the EHR agenda in England is going to be. Big, big question mark. Because both governments, both the new governments, the Liberal Democrats and the Conservatives, have said they basically want to scrap the national program.